Great, thanks everybody for being here. And I know we're gonna have more people filling in as time goes on here. It's early morning, but this is a great session we're having here today. And they're titling it I just want to read the synopsis just because I think it's a very important one here. It's Report from the Cancer Battlefield 50 Years Later. And what they talk about here, in 2021, 5 decades after President Richard Nixon declared a war on cancer, some 1.9 million new cancer cases were diagnosed, and the scourge killed more than 600,000 Americans. Yet we have made extraordinary progress in the battlefront in the same time frame. Childhood leukemia can often be cured. Death rates for colorectal, cervical, and prostate cancer have fallen by half, and treatment advances have rerouted the course of breast cancer, lung cancer, and melanoma. So how hopeful should we be? And to help me answer that, the experts in the field here. So thank you guys for being here. To my left, Peter Pisters. He's the president of the University of Texas MD Anderson Cancer Center. In the middle, Lisa DeAngelis. She's the physician-in-chief and the chief medical officer of Memorial Sloan Kettering Cancer Center. And at the end, Otis Brawley. He's Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. So thank you guys for being here with us. So. Peter, let's start with you, because I think one of the big things, even in my career in medicine, I've noticed big changes in standard of care. Again, in those 50 years, how has standard of care changed? Does standard of care need to change moving forward? Where are we with all that?
Well, I think that this piece of legislation was really dramatic and monumental and transformational because it helped us to really think about how we deliver cancer care. I think one of the biggest changes that occurred is that we recognized that oncology care or the care of the cancer patient is not an individual sport, that it requires teams, and that it requires a holistic assessment of the needs of the patient that go far beyond medical needs and include a focus on all dimensions of how cancer affects the patient and the family. That really allowed us to aggregate teams really around diseases, bring together surgeons, medical oncologists, radiation oncologists, but also individuals who were focused on the mental health challenges associated with having cancer, and then delivering that care in a team-based approach rather than the traditional model of healthcare, which is typically a physician and a patient. And I think that migration to team-based care and that focus on the holistic needs of patients have been some of the biggest changes that we've seen as a result of this.
And I know none of you were practicing prior to Nixon's time frame, but what was it like before then, historically, as far as cancer care? How was it treated then versus now that this has switched over and improved to this point? Any of you?
Lisa, do you want to jump in?
So I think that's a great question because there are enormous changes in care. So in 1971, first of all, even saying the word cancer or communicating that cancer was a diagnosis was really verboten. You did not do that. Patients, families, the public was really not ready to always accept that diagnosis. In fact, a huge transformation in that regard was in 1974 when then First Lady Betty Ford actually made public her breast cancer diagnosis, her mastectomy. She was photographed in a hospital bed and recovering. That was a transformative moment in the United States for communicating the issue of cancer. But back in the in the 70s and 80s, predominantly, it was surgery, usually very deforming surgery frequently, or life-altering surgery. Radiotherapy, which was not as precise as it is today, so there were often more common side effects than we see today. And chemotherapy was really just in early stages of development, and quite honestly, we did not know how to manage the toxicities of chemotherapy, such as nausea and vomiting, anywhere near the way we do now. So one of the huge shifts is not just better drugs, but much reduced toxicity associated with all the major modalities of treatment and a better quality of life for people while they're going through cancer care and afterwards.
Otis, what precipitated these changes? Because we talked about President Nixon basically pushing this forward. You know, President Biden's talked about the cancer moonshot. What's precipitated these changes over the last 5 decades, and what's going to push them forward?
Well, what the National Cancer Act did is it established a surveillance system so we could actually count. And by the way,
Right.
that's how we know there's a 31% decline in risk of cancer death since 1991 through that surveillance system. Most importantly, it put a lot of money into investigator-initiated research where doctors and professors at universities across the country could write a grant saying this is an important question, it needs to be researched, justify that question, and then they could get money through that research grant to do that question. The research pool went from 5% of a small amount of money to 50% of a large amount of money. And when you look at the outcomes from those research grants, we totally redefined what cancer is. We figured out it's a genetic disease. We learned a lot about what's going on in terms of metabolism and genomics inside the cell. All that basic research in the first 20 to 30 years led to the development of many drugs and many interventions that we have now. And you can even just watch the television now. You see commercials for nivolumab and other things. These are all drugs that came out of the National Cancer Act. And it was 50 hard years of research, a few Nobel Prizes coming along the way. But it was an intensive, basic science leads to the translation into patient treatment.
And opening it up to all of you. Go ahead, Lisa.
I was just going to say, and Otis, to add to that, the National Cancer Act also created the National Cancer Centers, which also created a distributed national model, if you will, of centers of excellence, so that people would have access to those advances and be able to also garner and engage with the talent that exists across the country to do the research.
That's right. It originally created 15 national cancer centers. We're from 3 of the original 15. Today, I think there's 71.
Yes.
Is that enough?
That's a good question.
I don't think so. I think that we've got comprehensive cancer centers in all the large metropolitan areas. But oncology care is not like a hip replacement or aortic valve replacement. It's not measured in days or a small number of weeks. It's longitudinal care delivered over months, and patients really need it at high quality, closer to home.
Yeah.
So we've certainly made progress going from 15 to 71, and that migration was really driven by the fact that you could get funding from the federal government if you established an NCI comprehensive cancer center that met certain standards. What then took place is that many universities built into their strategic plan a roadmap to get to NCI designated comprehensive cancer status. And boards pushed management teams to really move in that direction. And when a comprehensive cancer center was opened up in a community, the whole community celebrated because they knew what that meant for them and for their neighbors. So seeing that really amplified and seeing partnerships develop between resource-intensive organizations that have the ability to partner with others to really bring the standard of care up across the whole country. That's what we've really seen by proliferation of a series of cancer centers that meet defined standards.
And sticking with the cancer center subject, are cancer centers where we need them to be now, or do they need to change even more so to get that care to people to make sure that they're doing the optimal work? Lisa or Otis?
Well, I'll start out. I think the cancer centers need to evolve. We're now starting to stress community outreach and engagement, involving doctors and other hospitals in the community with the larger cancer center, involving community groups. I'm very much into the future of cancer is in risk reduction and prevention. We need to push the envelope on screening and treatment, but we also need to do as much as we can possibly do to prevent cancer. And there's some obvious looks at geography and various populations in geography to show that you can prevent a lot of cancer. And the way you do that is you get into the school systems, you start educating people about how to live a healthy life and a healthful life experience. And those are the sorts of things that I think are the new frontier, in addition to the molecular biology and some treatment that I'm really excited about.
This is such a good point, Otis, because we know that if we could just deploy what we know works today with regard to prevention, we could prevent somewhere between a third and a half of all cancers.
Right.
And so if we could just scale up, if we use implementation science, which allows us to take scientifically proven approaches that work in a pilot project and deliver them at scale to a population, we could reduce the cancer burden dramatically. The economic impact of that would be profound, and the upfront investment would have payback and return on investment and societal gains that are profound.
If I can just give one piece of data that illustrates that point. The death rate from cancer among college-educated American women is 60 deaths for every 100,000 college-educated American women. The death rate among high school graduates or high school dropouts is 120 per 100,000, exactly twice. That tells me, unless we're going to argue that the biology of women who are college graduates is different from the biology of women who are high school graduates, that we can do an awful lot in terms of preventing death.
Right, what Otis is really saying is that it's the social and behavioral determinants of health that are so important for us to focus on. And if we focus on things that we know today, like tobacco use, sun exposure,
Yes.
Obesity control, just to name three, you could really impact not just your risk for cancer, but heart disease, diabetes, and a whole host of other conditions that most of us would rather not have.
So prevention is essential and would do exactly what Peter and Otis are saying. And you don't need a comprehensive cancer center in your neighborhood to accomplish that. However, there will still be cancers diagnosed. And I think the issue of how, as a country, we provide access to high quality cancer care when a cancer develops, even despite the best prevention efforts, and of course there is screening and early detection efforts, which also could play a role in really dramatically reducing the burden of cancer in the population. We still have large parts of the country that don't necessarily have access to the level of cancer care that all of us here would like to see. And in particular, I think the rural areas of the country are exactly where there is if you look at the map of where the NCI designated cancer centers are in the country, for the most part, they're on the coast, and they cluster along the southern part of the country and all the major urban areas. And yet there's a large swath of the country sort of in the northern middle part that lacks this completely. At the same time, we have the paradox of, even in a place like my own city, New York, which has multiple NCI designated cancer centers, we still have areas, inner city populations, who don't perceive that they have access to care. And that's yet another obstacle that we need to overcome, because they technically have access, but they don't necessarily avail themselves of that access for a variety of reasons. And it's our job to figure out how we reach those communities.
And you guys have brought up a very important point about screening tests that we use frequently for different diseases. Example I can give you, prostate cancer. That screening test has changed and evolved because we know now that we were screening too many people. We were getting too much morbidity from people getting over-screened. Are we heading in the right direction? Do we need to change anything?
I do think we are. When we overuse a resource and misuse a resource, we actually create disparities, because those are resources that could have gone to the right thing. In the case of prostate cancer screening with PSA, it was well overdone and oversold 20 years ago. I think it's very appropriate now. Almost every organization that makes recommendations has a statement that's very similar, that talks about the pros and cons and what a man needs to know. We're moving in that direction with breast cancer screening as well. So I think as time has gone on, we have matured, especially in the area of screening and early diagnosis. The thing that I'm looking at now is how can we get more people involved in screening. For example, mammography screening. 12 studies tell us it reduces relative risk of death by 20 to 35%. Surveys that National Cancer Institute survey system that Richard Nixon founded tells us 40% of American women who should be getting mammography are not getting it. A third of people who should be getting some type of colon cancer screening are not getting it. You know, these are lives that could be saved. These are preventable deaths. That's where we need to look at now.
I think the screening issue is going to become very complicated, actually.
More complicated.
It's already very complicated, but the multi-cancer detection blood tests, which identify fragments of DNA in the blood that are presumably being shed by a unrecognized cancer, are really, I think, they have enormous potential to perhaps eliminate the need for things like colonoscopy and whatnot, which are invasive and difficult and not necessarily fun to go through. So people avoid them. And in that sense, there's enormous potential. At the same time, I think we don't yet know enough about what the false positive rate is, the consequences of a false positive rate. And the other issue is the anxiety associated with a positive blood test, a workup that seems negative, and then knowing even what to do about that, like how
And even that
often.
time frame in between, because often you'll get a positive blood test, 3 weeks later you'll get some kind of biopsy, that 2 weeks later you'll get a lab report.
So there's that is very anxiety provoking.
We need clinical study to develop these new tests. These new tests are they're about to come out, and we need clinical study to evaluate them for sure. And actually, one of the problems is you can get one of these tests, and the result can be the doctor says, well, I've got bad news, I've got good news, and then I've got really bad news.
Right.
The bad news is you've got cancer. The good news is we caught it early. The really bad news is we don't know what the hell to do about it or even where the cancer is.
But these tests are already on the market. People are using them. They cost about $1,000 a hit, which of course it's not covered by insurance. So we're already setting up a very challenging environment, I think, in terms of being able to do the essential studies, which will take a long time to really clarify. And so that's the other thing. We need patience.
And it's not just the blood test, but also imaging tests, because I know, MRIs are getting more detailed, CAT scans are getting more detailed, PET scans, everything's getting more detailed. And so I know as a physician, and this is a little secret in medicine, we often get this finding that there's something there.
Right.
Pathologists, the radiologists don't know what it is. Does it need a biopsy? Does it not need a biopsy? And as a doctor, you have to go ahead and work this up. But at the same time, part of you is saying, is this something that should even have been found?
Right.
What do we do with that? Just studies?
I'm struggling with that right now, as a matter of fact. No. We need more clinical study. We need to sit down and very carefully and logistically, and Lisa's right, the MCED is where this is coming up right now. We need to sit down and very consciously do good clinical trials, and we need to all understand that those clinical trials need to be done.
That is a real challenge right now, because we see the rapid pace of innovation and discovery. We see the impact of industry in particular driving deployment of technology, and we have a history that you described to with PSA testing that maybe in retrospect was rolled out a little too fast. We also have expensive technologies like proton therapy radiation treatment that was deployed at scale without necessarily the kind of evidence base that Otis and Lisa would like to see going forward. We saw minimally invasive surgery being pushed by technology companies without a real understanding behind it. And so we've got to be able to redirect people towards the kind of studies that allow us to have the body of evidence so we can sort out the wheat from the chaff and find unexpected findings that maybe are counterintuitive to the hypotheses that we have, like maybe we don't need to do PSA screening as often as we do, or maybe minimally invasive surgery shouldn't be used for certain types of cancer.
So, it's very challenging, I think, because on the one hand, we say early detection of a cancer leads to better outcomes, and saved lives, and that's true. On the other hand, we say, if we're seeing something on a scan that was found incidentally, or perhaps on these blood tests, and we don't discover anything even after workup, we're also in a position of saying, maybe we need to wait and see and not jump in and pursue every single little abnormality on a scan. That is not the appropriate way to deal with those things.
And notice you and I were talking about
Yeah.
It's hard to message that to the public,
And
right?
that's the hard part, telling your patient,
You're saying,
we found something, we're just going to watch it.
Yeah.
exactly, you're
yeah.
saying both things at the same time.
Over the last 100 years, we've taught the American public and doctors that cancer is bad, all cancer is bad, it needs to be cut out. One thing that came to us sort of as a surprise through the National Cancer Act and Nixon's war on cancer is we have redefined cancer. We have found, used to be we used what Virchow, the German pathologist, told us in the 1850s. He'd look at biopsies under the microscope and he'd draw pictures and he'd say, whenever you see this biopsy, this is cancer. This is what killed the person I am autopsying. Now with all of our new imaging technology, I can find a lesion in a woman's breast that's smaller than a green pea. I can find something 4 or 5 millimeters in size. And with new biopsy technology developed in the last 20 years, I can get a piece of it and I can send it to a pathologist. And the pathologist looking at it under the microscope using 1850s technology with a light bulb as a light source now, says this looks just like what Virchow said killed that woman in 1853. This is breast cancer. Now, because that thing is so small, it may not be genomically programmed to grow, spread, and kill. And so the new cancer definition of the 21st century is pathology and genomics. Do the genomic studies tell us this is an aggressive one that needs to be treated, or this is a benign one that needs to be watched? Now, as an epidemiologist, I can tell you 10 to 20% of mammographically found breast cancer doesn't need to be treated. That's as a population doc. As a doc with a woman in front of me, I can't tell that woman that she needs to be watched and not treated. In prostate cancer, it's become a little bit easier. The majority of those prostate cancers need to be watched.
So bridging that gap is important because that's the important part of the person sitting in front of you. And we've talked about how, population statistics are one thing, that person sitting in front of you. Will we be able to do that in 50 years?
I think so. I hope so.
I think so. I mean, one of the things that we're bumping up against is the complexity of delivering cancer care. What Otis just described, how is a rural doctor going to be able to navigate that kind of decision making? And when all of us were in medical school a while ago, likely in the last millennium, and we were studying about lung cancer, we were taught that there were just two types. Small cell and large cell.
Right.
And you could use the 1850s technology
Right.
and a 10x lens with a bulb, and you could look down a microscope and distinguish between those two types. They had somewhat different outcomes and they had different types of treatment. It was really simple. It was two subtypes and two forms of treatment. Now lung cancer has been completely transformed into molecular subtypes. And unless you have the subtyping technology and the right kind of lab access to be able to tell you what kind of subtype and what kind of mutation the tumor has, you have no idea how to treat the cancer. So in centers like ours, the complexity level of treating a common cancer has just moved up logarithmically. And the need to have molecular lab support at the ready, at the elbow, to help support decision making and accurate staging and proper use of tools like PET scanning has become super important.
And I hate to bring this card to, go ahead, Lisa.
And it's unrealistic, in all honesty, to expect even a medical oncologist in a rural area to even hope to keep up with every single nuance in all the different types of cancer, that the speed of discovery has just transformed. And that kind of actually brings us back to the first part of our discussion, which is the comprehensive cancer centers. I mean, we almost need a kind of a hub and spoke model.
Yes.
Because you can't expect to put a huge center comparable to MD Anderson, Sloan Kettering, Hopkins, in the middle of Montana. It's just not going to work, and I'm not picking on Montana, but the physicians who were there need to be able to reach into that expertise when they need it. We need to be able to provide them the kind of high-level testing that Peter's talking about, and be able to feed back to those physicians' guidelines and help them do the very best for the patient who's sitting in front of them. I just see this as sort of accelerating at a logarithmic level, because the speed of information that's coming out is just, it's astonishing. It's wonderful, but it's not something that a rural oncologist could possibly keep up with on their own without help.
Just to drive that point home again with some statistics that might be illustrative. There's been a 50% decline in risk of death from colorectal cancer from 1980 to 2018. Your average 50-year-old guy, his risk of dying from colorectal cancer is half what it was in 1980. The United States was very homogeneous in 1980. Now, keep on with the alliteration with M states. There's been a 20% decline in colorectal cancer deaths in Mississippi and a 60% decline in Massachusetts. Okay? 50% for everybody across the United States, but certain states have not enjoyed the decline in death rate from breast, colon, prostate, other things that other states have. You know, when I first got involved in health disparities, it was all black-white. Today, health disparities is rich, poor, Mississippi, Massachusetts, it's geographic and other things.
But one of the themes that's come out of this conference here this whole week is, and I hate to bring this card to the table, money, funding.
Yes.
These are not cheap to get that access in there. And like you said, the information is hitting us faster than we can absorb that information at times. And so having those experts in place, but that costs money. Where does that come from?
Well, not everything should cost money, actually. So if anything, you know, if COVID has taught us anything, that telehealth is incredibly powerful. And you can get expertise through telehealth. You don't necessarily have to see the patient. But I will say, something that people may not realize, a huge obstacle is state licensing problems, which were suspended during the pandemic and are now sort of being put back in place. So I can't consult on a patient in Montana, sticking with my M states.
And for those who don't know, there's no national medical license. Each state has their own medical boards and they license, and oftentimes that does not cross borders.
It almost never crosses borders. And so, I mean, that would be a step that doesn't cost money, that would really dramatically enhance access in some ways. Now, it doesn't explain the testing costs and things of that nature, but I do think if you had centralized areas, you could at least bring down the cost of these. The cost of things like sequencing has just fallen, I mean, just plummeted enormously. And the more you do, the cheaper it is, and the greater the expertise in being able to not just do it, you have to have somebody who can interpret it, which is even more important in some ways, and put it in a context.
Yeah. If I can just, you said it costs a lot of money. Let me just lapse into the research thing again. The investment of the National Cancer Act has given us tremendous in terms of cancer. The spinoffs in other diseases have been tremendous. Part of the reason we were able to get a messenger RNA vaccine for COVID so quickly was the investment in cancer research and other areas of research. There's spinoffs from the cancer research into other diseases all the time. That is something that we desperately need to invest in. And I don't want to leave without noting, and one of my jobs is to mentor young scientists. It's only about 10% of grants submitted to the NIH right now that are judged acceptable for funding that actually get funded. 1 out of 10 good ideas is currently getting funded. It's actually more like 9%, I think. we are losing a lot by not investing more in scientific research. Now, that's a little separate from the medical issue,
Right.
but we need to address both of them.
Yes.
We talked about access, especially in rural communities. That's a big issue. Telemedicine is one of those tools that can help alleviate part of that, but looking at a different level of this access, clinical trials. Because clinical trials are important to understand what the future is going to put, treatments, the diagnostics, all those things. People in rural areas tend not to participate in clinical trials because they can't access them frequently, or they can't stay in the area for 3 weeks for the clinical trial.
Right.
What do we do about that? Or is that a problem?
No, it's a problem.
Definitely
Oh, it's definitely a
Definitely a problem.
problem.
There have been efforts, the Community Clinical Oncology Program at the National Cancer Institute.
Sorry, let me ask you this. So I guess my question is not, is it a problem getting them in there, but is it a problem not having them in there? Is that giving us a
Yes.
skewed perception of
Yes,
things?
Yes.
yes,
Yes.
yes.
Lisa?
Yes, it's giving us a skewed perception because it doesn't reflect the whole population. But it also means that the trials take longer to complete, because if you can't accrue rapidly, it kind of goes on, and sometimes the relevance of the trial starts to become less critical because other advances are happening. So, it's very hard it's critical to do things in a timely fashion, the clinical trials, and the lack of participation is really an obstacle. The best example of that is the pediatric community. So pediatric cancer is fortunately very rare, but the pediatric community has really banded together, and they basically, a child with cancer, I believe more than 60% in the country are enrolled in a clinical trial. And the adults, it's about 5%.
That's right.
And the speed of discovery in pediatric cancer has been far greater for diseases that are much less common than it has been for adults in terms of turning over the studies and making the kinds of changes that impact care. We have a lot to learn from our pediatric colleagues, and we need to be more committed to clinical trial enrollment.
Now, the cancer centers, we put low of 15, high of 30% of our patients
Yes.
on trials. But there are lots of patients out in the community. And the National Cancer Institute has tried and has developed community programs to try to bring more community docs in so that our results can be more representative of the population. And when I design a clinical trial, I'm always trying to avoid what's known as the healthy patient effect. Where all the people who come onto my trial are Olympic athletes who just happen to have cancer. I want people with beer bellies, people who used to smoke, people who are representative of all of America on my clinical trials. And these are efforts to do it. But unfortunately, community docs have a lot of things to do, and to put patients on clinical trials can take away from those other things. But by the way, we've got studies to show if a doctor puts 2 or 3% of his or her patients on clinical trials, they take better care of the other 97, 98% compared to a doctor who does not take part in clinical trials at all.
So in about a minute here, I'm going to open up to questions. So just have your questions ready. Peter?
Yeah, one important point is that this diversity issue is now being recognized by the FDA. And as we move into the next era of oncology drug approvals, the FDA is going to require diverse populations enrolled in the study. That's a good thing because the outcomes of those studies will be generalizable to the whole population, which is what we want. Right. And we want to avoid the problem that Otis was alluding to, which in our language is referred to as selection bias. To get to the east side of Manhattan to Lisa's center, there's a certain activation energy, a certain degree of financial commitment. Generally, super obese people probably can't make it. And so the people that enroll in studies at
It's not that far, Peter.
The whole point is that the people that enroll in a study at Sloan Kettering, they're Olympic athletes. And you're going to get better outcomes simply through the selection process and through the enrollment. That's a byproduct of where the center is and the requirements to get to the center.
that access in Texas has to be an issue because it has a lot of rural areas. How do you guys address that?
It's a huge problem in all the large states, especially in Texas. I think part of the solution is what we were talking about before, the more widespread use of virtual care pathways for all elements of healthcare. And there are certain regulatory and reimbursement issues that were opened up during the pandemic that now need to be made permanent. And then there's the issue of broadband access, which is so important. Others refer to it as a digital divide, and we know that there's what we think of as a first mile effect and a last mile effect, meaning that if you go to telecom companies and say, you need to put broadband into West Texas, they will look at us and say, there's no market there.
Right.
I need your money, government, in order to put broadband in there. And then there's a last mile effect because the people who need the hookup from the telco company to their house can't pay the $85 per month. Right. And so we've got to really think carefully about how do we solve for both dimensions of that, because broadband access is like water and sewage. You've got to have it.
Especially today's day and age.
Yes.
Especially all this. Let me see any questions. Yes, ma'am. Let's wait for a microphone here because this is, it is actually taped. And so we want to make sure we get your question.
Well, good morning. This is so exciting what you're doing. MCED, multi-cancer early detection tests, I think really are a great example of the opportunities, but the things we need to worry about as well. We need to remember, first of all, these are in addition to mammography, colonoscopy, etc. So they'd be given to everybody once a year. They're $1,000.
Yes.
Medicare does not cover screening tests. Now, there are ways to get around that Medicare doesn't cover screening, but Medicare is mandated to not cover screening. So we have a situation where wealthy people who have $1,000 can get it. But will other people be able to get it? Assuming the evidence ever comes in that it really works.
Let me correct you a little bit. Medicare does cover screening tests where there's a prospective
Yes.
randomized trial
Yes.
that demonstrates that it prevents deaths. So Medicare will pay for mammography, Medicare will pay for cervical cancer screening,
Colonoscopy.
So there-
colon
yeah.
cancer
But
screening.
in general, they need the evidence in order to cover
I
it.
actually
as
think that's a
opposed
good
to-
thing. I think
Yeah.
it's a waste of money if you don't have the
But
scientific
these
proof to
tests
show
are here
benefit.
now. People can get them. So
I
it's
think
like,
that's
wow.
I think it's a good thing that we only pay for tests, that insurances only pay for tests where there's proof the tests work.
Yeah.
If an individual wants to buy a test where there's no proof that test works, this is America and they have that freedom.
Questions? Yes, ma'am. Oh, right here. You get the microphone. Right.
Well, no, Francis
Dr.
had his hand up.
Collins is over
I will
here.
defer to Francis
You
Collins.
see it? How you doing?
Check. There we go. Great panel. Really wonderful discussion, thinking about 50 years and also where we're going next. I'm currently privileged to serve as the acting science advisor to the president, and we will never, I think, have a president who is more committed to seeing progress in cancer than Joseph Biden, with the moonshot now being reignited to try to see what can be done on top of what's already there. There's a big debate going on about what should be in that next moonshot component, and lots of ideas being accumulated by the White House, particularly Danielle Carnival and myself. So I just want to ask the three panelists, if you had to name one thing that you think has to be included in order to make the most progress on ending cancer as we know it in the next version of the moonshot, with maybe some more money for it in FY24, what would be the thing you would identify saying that's got to be a flagship part of Moonshot 2.0? What would you put on that list? Because there's an active discussion going on right now about that.
Otis, do you want to start?
Yeah, my answer is probably different from everybody else's. I would really double down on risk reduction, trying to push and educate activities that lead to people not getting cancer. I think that's a great, cheap, long-term investment. I would not throw all my money into risk reduction or prevention. I would do some in early detection and treatment, but I think risk reduction has been tremendously shorted over the last few years.
Lisa?
I actually would agree with Otis, and in that bucket, I would actually include the hereditary syndromes. And the reason I say that is because the more we test people and study their germline, the more we're coming to understand how increasingly important a whole variety of genetic abnormalities are in predisposition. And while that's a small slice of the large cancer pie, if you will, I think with time it will become not only a larger slice, I think it's going to provide key insights in how, in cancer in general, and how we might adjust treatment accordingly.
Peter?
Francis, what I think we should focus on as part of what you're describing are novel ways to help the underserved with cancer right now. There are many, many people in our country who don't have access to the front door of American medicine and don't get the kind of care that we've been talking about in this session. One model that we could think about is if you use our institution as an example. I haven't really talked with you about this, Francis, but we have developed a partnership between the community in Houston that will come together with a lead gift of $50 million. That'll be augmented by another $20 million from our community. We will put in, as an institution, $70 million to create a $140 million investment, and we will build a cancer center at the Safety Net Hospital and operate it with our faculty. Now, what we could do is we could create 2 tiers of NCI-designated comprehensive cancer center. In Tier A, which gets more funding from the federal government, you have to do what happened in Houston. In Tier B, you get less funding, so you can reallocate the same funds to communities that want to come together, partner with the NCI-designated comprehensive cancer center to deliver state-of-the-art care to the underserved.
Great. Sir, back over the mic.
My name's Jeff Thompson. I'm a Peds ICU doc and the former CEO of a health system. And although I am completely with Otis on pushing the screening out into we need centers, but the centers can't be full themselves. They have to go out into the regional area. We have people that won't drive 12 miles to this other town to get a mammogram. We have to understand what's going on so we can get them screened. And it's our responsibility. It's not their, it's our responsibility to understand what they need and then meet them. My question for you is, how do you learn from each other's failures? And I know this happens. I mean, and I've spent my life making fun of people that stand up and talk about personal issues with this, but I know of a patient managed by a university center, very strong, that at different points of her cancer journey was seen at MD Anderson and at Sloan, treated wonderfully well, by the way, and not with Otis, unfortunately, but across the street at the NIH. And although treated well, had a complex breast cancer, eventually died, none of those organizations would know that. And none would know what her second and third biopsy of her liver would look like, and why their suggested therapies failed. So it is, I mean, I love the great centers, and I love the data, and I love the, pushing ahead on things. But what are we learning? In the PICU, we learn a lot from our failures. What are you learning from each other's failures along the way to advance things more quickly? Thanks.
I can't add to that, but I can except to say the introspection in our profession is something that I wish was better. I wish the reflection, we frequently don't de-implement things that we used to do that we now know don't work, of which there have been many, because we don't have introspection and we don't think about things like this.
There's another challenge, which is to get the information back into all the respective institutions, and we are very bad at that. So if we see somebody and then maybe they go home and it's 2,000 miles away, we may or may not ever hear what happens. So I'm hoping that through, maybe this is optimistic, but the electronic health record, becoming more harmonious across the country, and digital platforms that we can do exactly that, because we want to know what our failures are. You're absolutely right. We can't advance things if we don't know when it doesn't work and hopefully why it doesn't work.
These are good points. It's such a great question. I would respond in two different ways. One is to hit on the point that Lisa just made. That's the interoperability of electronic health record systems. Which,
Here. Yeah, you got it.
here we go. Right now, we have, in this country, we have a duopoly with two major players. And for proprietary reasons, they don't want their systems to be interoperable. That really is a barrier to good patient care and the issues that you're describing. The second thing is known among academics. It's what we refer to as publication bias in situations where if you have a negative trial result, you can't get it published because the journal has a business model that really is dependent on advertising, and they can't get the advertisers by continuing to publish negative studies. So negative results, which are super important, maybe just as important to disseminate as positive studies, don't get published. And that is an issue that we need to think through that relates to the business model of how academic journals are set up.
You know, you guys bring up good points, because with the electronic medical record, you know, I could go Google how many children under the age of 5 eat certain types of cereal in Boise, Idaho,
Right.
and get the information right away, but I can't find out what's happening to my patient if they saw somebody in another health system.
Exactly.
That's right.
Another question? Yes, ma'am.
Thank you so much. My question is, how can we apply this to other areas of health and healthcare? I think you guys have touched upon a lot of the difficulties and roadblocks, but cancer has come an incredible way in 50 years that other diseases haven't. I work in Alzheimer's, for example.
Right.
You know, cancer for us, what you guys do in cancer clinical trials is the gold standard and where we hope to be in 50 years with Alzheimer's. I previously worked in obesity prevention and social determinants of health, and there's very little energy compared to cancer. So what's the PR story? Where's the people story? Where are the lessons that we can apply to other disease states that you think that we've learned in the past 50 years?
You know, thank you for that question. You may not realize that I'm actually a neurologist by background and training, and sometimes I have said, you know, the curing cancer, be careful what you wish for, because the brain is kind of a brick wall on the therapy side that just hasn't made the same kind of advances, and there have been more sort of fits and starts in therapeutics, at least for those diseases. However, I would say I see optimism there, because there are more clinical trials in neurology than there ever were before. They haven't always been positive, but the fact that they're happening is a major step forward. And many of them, to your point, have been designed using kind of oncology templates, if you will, which I think, and obviously tweaked appropriately for the disease. But I am optimistic that therapeutics will come down the road there. And a lot of what Otis and Peter and we've all been talking about with prevention affects other diseases. So obesity prevention, I mean, heart disease is still the #1 killer of Americans, and obesity is critically important there, and control of diabetes and those other chronic illnesses as well. So I think on the prevention side, we could make America much healthier, even if we just focused on the cancers, if you will. You would see a downstream health issue much more widely.
And unfortunately, we could go on forever here, because this is a great conversation. We have literally 30 seconds left, but in a nutshell, answer the question we started with: how hopeful should we be?
Very.
Very.
Super hopeful.
All right, there you go. Thank you guys very much.
John, thank you.